Advanced Pharmacology Study Notes Diabetes. It is our responsibility to ensure patients are receiving the most appropriate treatment based upon current evidence and patient acceptance. It is also our responsibility to educate each of our patients about long-term side effects and benefits so informed decision can be made. The clinical course of diabetes mellitus 1 and diabetes mellitus 2. Type 1 DM, generally in younger persons, rapid rate of beta cell destruction and presentation with ketoacidosis. Young adults can maintain insulin secretion to prevent ketoacidosis for years and may have latent autoimmune diabetes in adults, LADA. Type 2 DM, very long preclinical period where insulin production declines and resistance continues to increase until compensatory mechanisms can no longer control blood glucose. Risk factors for DM2. Positive risk factors for DM: age over 45, first degree relative with diabetes, overweight with central obesity, hypertension, blood pressure greater than 140 over 90, or on therapy for hypertension, HDL cholesterol levels 250 or greater, physical inactivity. Consider lifestyle modifications which not only apply to prediabetes but patients with diabetes as well. Comorbidities. Micro and macrovascular complications are associated with DM. There are interventions that can be used to prevent or treat them besides glucose control. That is, these medications should be used as adjunct to blood glucose lowering interventions in all patients with DM, barring contraindications. These interventions have been demonstrated to improve long-term outcomes. In red, don't forget about them in your comprehensive treatment plan. Hypertension. For people with a blood pressure greater than 120 over 80, lifestyle intervention consists of weight loss when indicated, a dietary approach to stop hypertension, which is DASH, style eating pattern, including reducing sodium and increasing potassium intake, moderation of alcohol intake, and increased physical activity. People with diabetes and hypertension qualify for antihypertensive drug therapy when the blood pressure is persistently elevated, greater than 130 over 80. The on-treatment target blood pressure goal is less than 130 over 80 if it can be safely attained. Treatment for hypertension should include drug classes demonstrated to reduce cardiovascular events in people with diabetes. ACE inhibitors or angiotensin receptor blockers are recommended first-line therapy for hypertension in people with diabetes and coronary artery disease. An ACE inhibitor or angiotensin receptor blocker at the maximum tolerated dose indicated for blood pressure treatment is the recommended first-line treatment for hypertension in people with diabetes and urinary albumin to creatinine ratio greater than 300 milligrams per gram, creatinine or 30 to 299 milligrams per gram creatinine. The AACE, which is the American Association of Clinical Endocrinology, AACE has a set systolic blood pressure goal for the majority of patients with type 2 diabetes as less than 130 of systolic and diastolic less than 80. A lower target can be considered for persons with micro or macroalbuminuria. Moderate or high risk for or with established ASCVD, peripheral vascular disease, or retinopathy. It is recognized that some persons with type 2 diabetes may not tolerate a goal of less than 130/80, including those with autonomic neuropathy, with orthostatic hypotension, acute coronary syndrome, frailty, or medication intolerance. The ACC-AHA goal of less than 130/80 is appropriate for most patients. Its less stringent goals may be considered for frail patients with complicated comorbidities. The KDIGO, the Kidney Disease Improving Global Outcomes, recommended for the treatment of patients with CKD, modestly elevated, 30 to 299 milligrams in a 24 hours, or higher levels greater than 300 milligrams in a 24 hours of urinary albumin excretion, even in those without DM. Delay progression of neuropathy in type 1 with or without hypertension and any degree of albuminuria. Delay progression of nephropathy in type 2 with or without hypertension and microalbuminuria. Reduce development of microalbuminuria, kidney disease, in type 2 with or without hypertension. The bottom line, of the agents available to control the complications of diabetes mellitus, cardiovascular drugs, and particularly ACE inhibitors, have a preeminent place. Experimental and epidemiological data suggests that activation of the renin-angiotensin-aldosterone system plays an important role in increasing in the micro and macrovascular complications in patients with DM. Not only are ACE inhibitors potent anti-hypertensive agents, but there is a growing body of data indicating that also they have a specific organ protective effect for the same degree of blood pressure control compared with other anti-hypertensive agents. ACE inhibitors demonstrate function and tissue protection of considered organ. ACE inhibitors have been reported to improve kidney, heart, and to a lesser extent eye and peripheral nerve function of patients with DM. These favorable effects are the result of inhibition of both hemodynamic and tissular effects of angiotensin II. Cardioprotective dose. Aspirin, i.e. baby aspirin or clopidogrel as an alternative. For secondary prevention of CV events, use in all diabetics with CV disease. Note, many authorities consider DM to be an ASCVD risk equivalent. For primary prevention of CV event, use in high CV risk patients, which are typically male greater than 50 years old, female greater than 60 years old, with one additional major risk factor, such as FH of CVD, hypertension, smoker, dyslipidemia, or albuminuria. May consider intermittent CV risk patients or younger patients with one or more risk factors, older patients with no risk factors. Not recommended in low CV risk patients, men less than 50 or women less than 60 without major CV risk factor. Statins. For all patients 40 to 75 with diabetes, moderate intensity statin is indicated regardless of baseline LDL. High intensity statin should be considered in those with a 10-year risk greater than 7.5%. For patients with diabetes aged less than 40 years with additional atherosclerotic cardiovascular disease risk factors, consider using moderate intensity or high intensity statin and lifestyle therapy. For patients with diabetes aged greater than 75 years with additional atherosclerotic cardiovascular disease risk factors, consider using moderate intensity or high intensity statin therapy and lifestyle therapy. ADA guidance. Primary prevention. For people with diabetes aged 40 to 70 years without atherosclerotic cardiovascular disease, use moderate intensity statin therapy in addition to lifestyle therapy. It is reasonable to consider the same in older over 75 and younger 20 to 39-year-old patients. For people with diabetes age 40 to 70 at higher cardiovascular risk, including those with one or more atherosclerotic cardiovascular disease risk factors, it is recommended to use high-intensity statin therapy to reduce LDL cholesterol by greater than 50% of baseline and to target an LDL cholesterol goal of less than 70. Secondary prevention. For people of all ages with diabetes and atherosclerotic cardiovascular disease, high-intensity statin therapy should be added to lifestyle therapy. For people with diabetes and atherosclerotic cardiovascular disease, treatment with high-intensity statin therapy is recommended to target an LDL cholesterol reduction of greater than 50% from baseline and an LDL cholesterol goal of less than 55 milligrams per deciliter. Addition of ezetimibe or PCSK9 inhibitor with proven benefit in this population is recommended if this goal is not achieved on maximum tolerated statin therapy. Unless contraindicated, a statin should be used as the first-line therapy for dyslipidemia in persons with type 2 diabetes. High-risk patients should be started on moderate intensity statin therapy. For persons at very high risk, high intensity statin therapy should be started regardless of baseline LDL-C levels. Glycemic goals. The primary target for glycemic control is the HbA1c. Individualized A1C goals based on duration of diabetes, age, life expectancy, comorbid conditions, known CVD or advanced comorbid conditions, hypoglycemic unawareness, individual patient considerations. Lifestyle modifications and glucose monitoring are forefront. Next, you can see that depending on the presenting A1C, initial therapy may be with 1 agent, 2 agents, or 3 agents, including the possibility of insulin or GLP-IRA. This also reiterates the fact that no more than 3 non-insulin agents should be combined. Those patients with comorbidities such as ASCVD or those at risk for ASCVD, CKD, TIA, stroke, or HF, in these patients, there are specific classes of medication that not only help with glucose control, but provide morbidity and mortality benefits in terms of the comorbidity. Diabetes care. Metformin, if not contraindicated and if tolerated, is the preferred initial pharmacological agent for type 2 diabetes. It reduces macrovascular complications in obese patients. It reduced all-cause mortality and risk of stroke compared to intensive therapy with insulin or sulfonylurea. Reduced diabetes-related death in MI versus conventional therapy. Contraindications to metformin include eGFR less than 30, severe worsening of CHF, lactic acidosis, concurrent radiocontrast dye, etc. Now this is in red. Please note, it is important to reevaluate the appropriateness of oral medications when a patient starts injectable agents. GPL-1 RAs can be used in combination with all oral agents except DPP-4 inhibitors. When insulin is started, metformin should be discontinued. TZDs should be stopped or the dose should be reduced. Sulfonylureas should be stopped or the dose should be reduced, especially if prandial insulin is initiated. SGLT2 inhibitors can be continued, although the patient should be educated about the risk of DKA, and DPP-4 inhibitors can be continued. GLP-1 RA can be continued, although the patient should be educated about the risk of hypoglycemia, etc. Options to add basal insulin for prandial coverage. Fast-acting insulin, DPP-4 inhibitors, incretin mimics, glycanides, alpha glucosidase inhibitors, colsevelam. What are the various types of oral and non-insulin medications, and what represents a rational combination of medications? Combinations should have different mechanisms of actions. Combinations should avoid overlapping ADRs. Combinations should ideally be selected based on need for better basal versus postprandial control. Selection should account for patient-specific concerns, e.g., CVD risk, etc. So your fasting glucose basal options: metformin, glidazones, sulfonylureas, NPH insulin, long-acting insulins. Postprandial options: glinides, alpha glucosidase inhibitors, covalent DPP4 inhibitors, incretin mimetics, fast or rapid acting insulins, and pramlintide, and then SGLT2 for both. What anti-diabetic medications have compelling indications? For those with underlying ASCVD or at high risk for ZVD, for those with CKD, for those with a compelling need to avoid hypoglycemia, for those where weight is an important consideration, such as which are associated with weight loss, weight gain, or weight neutral. What are the precautions? SECI, example, TZD associated heart disease, heart failure, weight gain, edema, osteoporosis. GLP-1RAs are contraindicated in patients with a history of thyroid, medullary carcinoma, or pancreatitis. Note, other medications, well, that's a chart that you can't see, so I'm not going to read that. Insulin, the only option in DM1. Most people with type 1 diabetes should be treated with multiple daily injections of prandial and basal insulin or continuous subcutaneous insulin infusion. It also may be an option in DM2. What are the various insulins, and describe the pharmacokinetics, onset, peak, duration, and how they are used? All right, this is in red. Basal bolus, long-acting basal plus rapid fast-acting bolus provides the greatest flexibility and control of all regimens. Sliding scale should not be used. It's difficult to do in home setting, requires education and understanding of patient and caregiver, allows the patient to become hyperglycemic, better to schedule dosing and prevent rises in blood glucose, requires frequent blood glucose monitoring. It's expensive and there are compliance issues. Again, in red, can be used as monotherapy or as add-on therapy for type 2 diabetes presenting A1Cs of 9 plus, symptoms or failure to achieve goal A1C on adequate trial of 2 to 3 agents at maximally tolerated doses. Often starting with a long-acting insulin. When glycemic goals aren't reached despite basal insulin, so good fasting blood glucose and prandial blood glucose, but elevated hemoglobin A1C, consider Prandial therapy with fast-acting insulin. Begin fast-acting insulin before the largest meal. Variation exists between the ADA and ACCE in their recommendations. If hemoglobin A1C is still elevated, add fast-acting to another meal. Sulfonylurea can continue up until the point where prandial rapid-acting insulin is added. This is in red. Metformin can and should continue. Other agents may need dose adjustments, and secretagogues should be discontinued at this point. Consider insulin in severely uncontrolled hyperglycemia, elevated glucose despite maximally tolerated oral therapy, gestational diabetes in pregnancy, comorbid illness that makes control with oral agents difficult, such as MI, infections, renal or hepatic disease, intolerance to oral medication. This is in red. Insulin advanced drug reactions, hypoglycemia, injection site reactions, lipotrophy caused by insulin antibodies, lipohypertrophy caused by injection into the same site, weight gain, increased abdominal fat, and questionably cancer. How is therapy monitored, and how should the results be interpreted? Self-monitoring blood glucose. Target reaching fasting and preprandial glucose goals first. Target ppbg if hemoglobin A1C goal is not met despite meeting fasting blood glucose and preprandial glucose goals. How does treatment in the hospital setting differ from outpatient? No studies have evaluated oral agents on outcomes in hospitalized patients. Sick days. Managing hypoglycemia, glucose alert value of less than or equal to 70 milligrams per deciliter. Individuals with diabetes can experience symptoms of hypoglycemia at varying blood glucose levels. The causes: too much insulin or medication, improper timing of the dose, excessive exercise, not enough food, delayed or missed meal, neuropathy, advanced age, ETOH. Individuals at high risk for hypoglycemia should be asked about symptomatic and asymptomatic hypoglycemia at each encounter. Glucose of 15 to 20 is the preferred treatment for the conscious individual with hypoglycemia. Okay, so this reads weird. If they present with hypoglycemia and they are conscious, they want you to give them glucose. The rule of 15. 15 grams of simple carbs. Check blood glucose in 15 minutes. Repeat until blood glucose is greater than 70. Examples of 15 grams of carbohydrates may include a small box of raisins, 4 ounces of orange juice, 8 ounces of skim milk, or 3 to 4 glucose tablets. Glucagon should be prescribed for all individuals at significant risk of level 2 hypoglycemia, and caregivers or family members of these individuals should be instructed on its administration. Sulfonylureas, second generation, so that's glypyride, glyphosate, and glyburide. Sulfonylureas have been the primary oral agents for type 2 for nearly half a century. The sulfonylureas are insulin secretagogues that stimulate the release of insulin from your pancreas. While they initially have high glucose lowering efficacy, sulfonylureas generally have low durability. Glyburide has an active metabolite which increases its exposure and the risk of hypoglycemia. For this reason, glyburide is contraindicated in older adults. Meglitinides, which is nataglinide and ripaglinide. Meglitinides are secretagogues, oh my gosh, I am so sorry, but that's crazy, that stimulate insulin release from the pancreas. Due to their rapid onset and short duration of action, these drugs are dosed multiple times per day and appear to have a lower incidence of hypoglycemia than sulfonylureas. Furthermore, the extent of insulin release appears to be glucose dependent and diminishes at low levels, which could also explain the lower incidence of hypoglycemia experienced with these drugs. Both ripaglinide and nataglinide target post-meal glucose spikes, now considered to be an independent risk factor for the development of macrovascular complications. Biguanide, which is metformin. Metformin's primary mechanism of action is to decrease hepatic glucose production. Secondarily, metformin increases peripheral uptake and utilization of glucose and decreases intestinal glucose absorption. Metformin remains the first-line medication management option for individuals with type 2 diabetes based on its high efficacy, low cost, and good safety profile. Metformin as monotherapy was shown to reduce all-cause mortality in obese patients by 1/3 in the United Kingdom prospective diabetes study. Modest weight loss and favorable effects on lipid profile also occur in patients on metformin therapy. Studies also indicate that metformin improves endothelial function by increasing acetylcholine-stimulated arterial blood flow in patients with peripheral vascular disease. In addition, metformin has been shown to reduce the overall cancer risk in individuals with type 2 diabetes. Metformin is contraindicated in individuals with renal insufficiency, and dose adjustments should be considered when GFR is less than 45. Alpha glucosidase inhibitors, which is acarbose or miglatol. Alpha glucosidase inhibitors delay the absorption of complex carbohydrates by inhibiting glucosidase enzymes in the brush border of the small intestine. The result is a reduction in peak postprandial glucose concentration. These drugs tend to be most useful in the early stages of the disease, with only mildly elevated A1C in patients experiencing relatively high blood glucose levels after meals and in patients with relatively normal fasting blood glucose levels. The side effect profile of this class of drugs, which includes flatulence, may limit their use. Thiazolidinidinones, which is pioglitazone and rosiglitazone. Thiazolidinediones are sometimes referred to as glitazones or TZDs or insulin sensitizers. These compounds reduce insulin resistance and normalize blood glucose levels by directly stimulating peroxisome proliferator activated receptor gamma, PPAR-Y, on the nuclear surface of many insulin-sensitive tissues, muscle, adipose, and liver, causing an increase in the transcriptional process for the production and translocation of glucose transporter 4, GLUT4, to the cell surface. This effectively leads to an increase in insulin-dependent glucose disposal in skeletal muscle and adipocytes. Decreases in blood glucose can be seen within 2 to 4 weeks after beginning therapy, but maximum glucose lowering may take up to 12 weeks. TZDs can increase HDL-C, and there is inconclusive evidence regarding whether pioglitazone reduces CV endpoints and prevents hepatic stenosis. Ooh, that was a mouthful. GLP-1 receptor agonist. So this is the exenatide extended release, liraglutide, lixisenatide, dulaglutide, and semaglutide. So all the tides are the GLP-1 receptors. GLP-1 receptor agonists primarily aid in glucose control during the postprandial period and are delivered subcutaneously. This drug class works by binding to the GLP-1 receptor, resulting in an increase in glucose-dependent secretion of insulin from the B cells of the pancreas, and a glucose-dependent reduction in glucagon secretion on the part of the alpha cells of the pancreas. These drugs also target multiple other defects of type 2 diabetes, including those not addressed by traditional medications. For example, they promote satiety and slow gastric emptying. In addition, the use of GLP-1 receptor agonists has been associated with weight loss and may increase beta cell function by improving first phase insulin response and increasing the beta cells' sensitivity to glucose. GLP-1 receptor agonists have differing structures, duration of action, efficacy, weight reduction, and side effect profiles. In general, the short-acting agents, exenatide and lixisenatide, have greater effect on the postprandial blood glucose values after the meals with which they are administered. For the GLP-1 receptor agonist with a longer duration of action, semaglutide, dulaglutide, and exenatide (ER), there is an increasing effect on fasting blood glucose in addition to the postprandial effects. Additionally, the GLP-1 receptor agonists have differing cardiovascular outcomes in trial CVOT's data. There may be favorable CV benefit for individuals with ASCVD with strongest evidence for liraglutide, favorable evidence for semaglutide and dulaglutide, and uncertain evidence for exenatide (ER). Exenatide is administered twice daily within 60 minutes of breakfast and dinner. In clinical trials, exenatide was shown to lower A1C by approximately 0.7 to 0.9% as monotherapy. Liraglutide is administered once a day at any time of the day, independent of meals. Liraglutide was associated with a 1 to 1.5% reduction in A1C when used as monotherapy and in combination with other anti-diabetic agents. Lixisenatide is administered once a day within 60 minutes prior to the first meal of the day. Lixisenatide was associated with an 0.8 reduction in A1C when used as monotherapy. Exenatide ER is a long-acting formulation of exenatide indicated for once-weekly injection. In clinical trials, it has been associated with a 1 to 2% reduction in A1C and a more robust lowering of fasting blood glucose than the exenatide that is administered twice daily. Exenatide ER is administered once weekly at any time of the day with or without meals. Prior therapy with exenatide is not required when initiated exenatide ER therapy. Dulaglutide is a longer duration of action which allows for once weekly injection independent of meals. Dulaglutide has been associated with up to a 1.5% reduction in A1C when used as monotherapy. Semaglutide is administered once weekly. It has been associated with up to 1.6% reduction in A1C when used as monotherapy. Amylinomimetics, so pramlintide. Pramlintide is a synthetic analog of amylin, which is secreted with insulin to slow gastric emptying, increases satiety, and suppresses glucagon secretion. It is currently approved for use in type 1 diabetics as an adjunct treatment in patients who use mealtime insulin therapy and in type 2 diabetes as an adjunct treatment in patients who use mealtime insulin therapy with or without sulfonylurea and or metformin. Pramlintide is available in a pre-filled pen for injection and is administered subcutaneously before each meal. The dose of pramlintide or mealtime insulin must be reduced by 50% when starting therapy with pramlintide. The dosing of pramlintide is different for individuals with type 1 and type 2 diabetes. Care must also be taken not to use the same injection site repeatedly, and selection of injection site should be distinct from the insulin injection site at least 2 inches away. DPP4 enzyme inhibitors. This is alogliptin, linagliptin, saxagliptin, sitagliptin. This class of drugs inhibits the DPP4 enzyme, resulting in a decrease in breakdown of GLP-1 and glucose-dependent insulinotropic polypeptide, GIP. The resulting effect is to increase insulin release from the beta cells of the pancreas and decrease glucagon secretion from the alpha cells, both in a glucose-dependent manner. Due to the need for pancreatic beta cell function, these drugs are approved only for use in type 2 diabetes. Unlike sitagliptin, alogliptin, and saxagliptin, linagliptin is primarily excreted unmetabolized via bile and gut, suggesting no dose adjustment is required in patients with renal or hepatic impairment. DPP4 enzyme inhibitors reduce the A1C by up to 0.7%. They have an attractive side effect profile in that they are weight neutral and they have an extremely low incidence of causing hypoglycemia. This makes them particularly attractive for early intervention in the management of type 2 diabetes. CVOTs demonstrated CV safety but no CV benefit with saxagliptin, alogliptin, and sitagliptin, and inconsistencies regarding heart failure for saxagliptin and alogliptin. Sodium glucose cotransporter 2, SGLT2 inhibitors. Canaglifloxin, dapaglifloxin, erutaglifloxin, and empaglifloxin. This class of drug inhibits SGLT2, which is found in the proximal tubule of the kidney. All the glucose that the kidneys filter is reabsorbed along the nephron by either SGLT2 or SGLT1, 90% versus 10% respectively. The FDA approved canaglifloxin in March 2013 as the first drug in the SGLT2 inhibitor class, which was followed by dapaglifloxin, empaglifloxin, and erutaglifloxin. The glucose-lowering efficacy of SGLT2 inhibitors is dependent on renal function and ranges from 0.9 to 1.2%. Its insulin-independent mechanism of action works by reducing glucose reabsorption, which increases urinary glucose excretion with a consequent lowering of plasma glucose levels in addition to the glycemic reduction. Studies also indicate that patients may experience weight loss and reductions in systolic blood pressure. Bile acid sequestrants, so colcivilam HCl. Colcivilam is the only bile acid sequestrant currently indicated as adjunct to diet and exercise in the management of type 2 diabetes. Compared with other anti-diabetic agents, it is relatively weak in its ability to lower blood glucose. Typically, A1C reductions of 0.5 and fasting blood glucose reductions of approximately 14 milligrams can be expected. Dopamine agonists, bromocriptine. Bromocriptine mesylate is a dopamine D2 receptor agonist that increases dopaminergic tone in the CNS, which results in reduction of hepatic glucose output, free fatty acid levels, triglyceride levels, insulin resistance, and an overall improvement in glucose tolerance. Bromocriptine mesylate is indicated as an adjunct to diet and exercise in the treatment of adults with type 2 diabetes. The A1C reduction with bromocriptine mesylate is approximately 0.3% with little or no effect on fasting blood glucose levels. Insulin therapy. Insulin is often indicated in patients with type 2 diabetes, particularly after several years of disease progression. Insulin is also indicated in newly diagnosed type 2 DM patients with markedly elevated plasma glucose levels or in primary failure of oral anti-hyperglycemic therapy. Additionally, patients may be given insulin on a temporary basis for stress-induced hyperglycemia. Other indications for insulin in patients with type 2 DM include surgery, pregnancy, renal or hepatic disease, uncontrolled weight loss, or the development of severe hyperglycemia with ketones. Many factors must be taken into consideration when selecting initial therapy. Okay, we're almost done with diabetes. I know this is long. Sorry, I lost my place trying to look and see how much we had left. Adverse effects. Sulfonylureas are associated with hypoglycemia and weight gain. These drugs should be used with caution in patients with hepatic dysfunction, chronic renal disease, elderly patients, and patients with increased risk of hypoglycemia. Meglitinites are associated with weight gain and hypoglycemia. However, the incidence of hypoglycemia reactions appears to be less than that associated with sulfonylureas. This is due to, in part, the drug's rapid onset and short duration of action. Metformin's primary side effects are GI complications such as abdominal bloating, anorexia, diarrhea, and nausea. Lactic acidosis occurs rarely with metformin in 0.03 cases per 1,000 patients per year. Because of this risk, metformin should be avoided in patients with renal or hepatic disease, alcoholism, and medical conditions leading to hypoxic states such as acute heart failure and COPD. Caution should also be exercised when using metformin in patients with vitamin B12 and folic acid deficiency due to metformin's ability to decrease absorption of both nutrients. Alpha glucosidase inhibitors have common adverse effects on flatulence, abdominal pain, and bloating. Patients with a history of inflammatory bowel disease, colonic ulceration, partial intestinal obstruction, and those predisposed to intestinal obstruction are not good candidates for these drugs. Furthermore, individuals with any disease or condition that may deteriorate as result of increased gas formation in the intestines are also not good candidates. Sorry, I lost my place. One second, we're almost done. Just let me go back to my place. All right. Thiazolidinones have been reported to cause mild to moderate weight gain and edema in some patients. These drugs are contraindicated for use in patients with New York Heart Association class 3 or 4 heart failure. In addition, TZD should be used with caution in patients at risk of heart failure with edema and those with a heart class of 1 or 2 heart failure or symptomatic heart failure since cases of heart failure have been reported in patients with both with and without previously known heart disease. An increased incidence of edema and cardiac failure has been observed with the combination of insulin and TZDs. Patients using insulin in combination with TZDs should be monitored closely for CV adverse events, and TZDs should be discontinued if any deterioration in cardiac status occurs. Macular edema and increased risk of bone fracture have been reported with TZDs during post-marking surveillance. Therapy with TZDs may result in resumption of ovulation in some premenopausal and ovulatory women. As a result, these patients may be at increased risk for pregnancy because troglitazone, the first TZD to be marketed, was associated with rare cases of severe idiosyncratic hepatocellular injury. TZDs should not be used in patients with clinical evidence of active liver disease or with increased baseline liver enzyme levels. Minor reductions in hemoglobin and hematocrit may also occur with the use of TZDs. There is an increased risk of bladder cancer, prostate cancer, and pancreatic cancer in individuals taking pioglitazone, which corresponds with increasing dose and duration of use. Therefore, pioglitazone should not be used in patients with active bladder cancer, prostate cancer, or pancreatic cancer. GLP-1 receptor agonists are primarily associated with nausea, vomiting, diarrhea, and dyspepsia. While it was initially thought that there was an increased risk for pancreatitis, pancreatic cancer, or bone disease with its drug class, there does not seem to be a substantial risk, though the packaging insert still lists pancreatitis as potential concern. Agents in this class have all been associated with an increased risk of gallbladder events. Exenatide should not be used in patients with severe renal impairment or ESRD. In addition, exenatide is not recommended in patients with severe GI disease due to the nausea, vomiting, diarrhea it may cause. Because exenatide can reduce gastric emptying, Use caution when administering exenatide to patients taking oral medications requiring rapid absorption or dependent on threshold concentrations for efficacy, such as contraceptives and antibiotics. Semaglutide, delaglutide, liraglutide, and exenatide ER were shown to cause dose-dependent and treatment duration-dependent thyroid C cell tumors at clinically relevant exposure in rats. It is unknown whether these agents may cause cancer in humans. Therefore, the prescribing information contains a black box warning regarding this issue and is contraindicated in patients with a personal or family history of medullary thyroid carcinoma, MTC, or in patients with multiple endocrine neoplasia syndrome type 2. Additionally, the SUSTAIN 6 trial found semaglutide was associated with increased retinopathy complications, mainly in those with baseline retinopathy who had rapid improvement in glycemic control. Pramlintide has been associated with nausea, vomiting, dyspepsia, and hypoglycemia when initiating pramlintide therapy. The dose of short or rapid-acting insulin should be reduced by 50%. Frequent glucose monitoring is important. Pramlintide is contraindicated in patients with confirmed diagnosis of gastroparesis and hypoglycemic unawareness. DPP-4 inhibitors are associated upper respiratory tract infections, nasopharyngitis, urinary tract infection, and headache. Hypoglycemia is also more common with these drugs when used in combination with sulfonylurea. There have been post-marketing reports of acute pancreatitis, including fatal and non-fatal hemorrhagic or necrotizing pancreatitis in patients taking these drugs. The FDA issued a warning that DPP-4 inhibitors may be associated with potentially severe and disabling joint pain. Additionally, further investigation is needed to explore the possibility of saxagliptin increasing the risk of hospitalization for heart failure. Clinicians should also use caution when prescribing alogliptin in individuals with heart failure. Dosage adjustments are recommended in patients with moderate or severe renal insufficiency and in patients with ESRD who are taking sitagliptin, saxagliptin, and alogliptin. There have been post-marketing reports of serious allergic and hypersensitivity reactions in patients treated with these drugs, such as anaphylaxis, angioedema, and exfoliative skin conditions, including Stevens-Johnson syndrome. SGLT2 inhibitors are associated with vaginal yeast infections, urinary tract infections, and increased urination. Hypoglycemia, dehydration, dizziness, and fainting have also been reported. Hyperkalemia has also been reported with canagliflozin. All SGLT2 inhibitors require dose adjustments and have contraindications based on eGFR. Canagliflozin should not be used in individuals with an eGFR less than 45 and is contraindicated in severe renal impairment, ESRD, or in patients on dialysis. Dapagliflozin should not be used in individuals with an eGFR less than 60. Imadagliflozin should not be used in individuals with an eGFR less than 45. Ketoacidosis requiring hospitalization has been reported with SGLT2 inhibitor. Thus, SGLT2 inhibitors should be used with caution in those with insulin deficiency. Dapagliflozin demonstrated an initial concern of bladder cancer, which limited its use. The FDA issued a warning that camaglifloxacin may be associated with an increased risk of bone fractures and decreased bone mineral density. Why the hell would you use any of these meds when there's better options? Bile acid sequestrants such as colsavelum may cause increases in triglyceride levels and may decrease the absorption of fat-soluble vitamins. Due to its constipating effect, coleveslin is not recommended for patients with gastroparesis and GI motility disorders. Bromocriptine mesylate may cause orthostatic hypotension and syncope, particularly upon initiation or dose escalation. Furthermore, the drug is known to cause somnolence and may exacerbate psychotic disorders or reduce the effectiveness of drugs that treat psychosis. Bromocriptine mesylate should not be used in patients with hypersensitivity to ergo-related drugs, patients with syncopal migraines, and nursing women. Bromocriptine mesylate is extensively metabolized by CYP3A4. Use caution when co-administering strong inhibitors, inducers, or substrates for CYP3A4. In addition, bromocriptine mesylate may increase ergo-related side effects and reduce ergo effectiveness for migraines if co-administered within 6 hours of ergo-related drugs, such as phenothiazines, butyrophenerones, thioxanthines, and metoclopramide. Insulin therapy is associated with dose-dependent side effects, including hypoglycemia, edema, and weight gain. Effects on existing atherogenic markers. Likelihood of adherence. Many patients have difficulty adhering to multiple daily injections of insulin, which is often required in type 2 patients with significant beta cell decline. Sulfonylureas can be taken orally once daily and are associated with weight gain and hypoglycemia, which may decrease adherence. Metformin and alpha-glucosidase inhibitors and exenatide need to be taken in relation to meals and are associated with significant GI complaints that may negatively affect adherence. Meglitides may also be associated with poor adherence due to multiple day dosing. TZDs are associated with weight gain, which may affect adherence. GLP-1s are subcutaneous injections, which may also affect adherence. Drug cost varies considerably among oral hypoglycemics, and managed healthcare plans may restrict use of some agents. Whew, we're done.